I am connecting with YouTube to begin because we are 7:00.
Okay.
Let me do the introduction before your. I am. Okay. Okay, we are on YouTube also, and okay, I will pass to you the command. Okay.
Okay.
But first, let me, Michael. Okay. Give me 30 seconds to do the introduction, okay?
Okay.
You have the command right now. If you want,
okay. Yeah, I will
share
share.
your talk.
Yep. Voy a hacerlo.
Ok, vamos a comenzar nuestra sesión. Es un placer para mí, es un gusto muy grande tenerlo a Michael Kurtz. Michael Kurtz es un profesor asociado del Servicio de Urología Pediátrica del Departamento de Urología en el Boston Children's Hospital y es también profesor de la Universidad Médica de Harvard. Michael es un especialista en varias ramas, pero principalmente tiene una afición muy grande y una experiencia muy buena en la parte de intervención fetal y diagnóstico prenatal. Entonces quiero dar la bienvenida a mi amigo Michael Kurtz para comenzar. También quiero dar la bienvenida a mi doctor Anthony Caldamone, que siempre nos está prestigiando con su presencia, y el profesor Nuncio Vicente de Chiara, que también está con nosotros para eventualmente dar alguna opinión. Todas las preguntas, por favor, les voy a rogar que las hagan a través de preguntas y respuestas. No lo hagan a través del icono del chat porque da un poquito de trabajo. Nada más que decir, please, Michael, you can begin. Thank you.
Ok, muchísimas gracias a German y su hospital por invitarme a hablar sobre uno de mis temas favoritos. Tengo una divulgación. Boston Scientific proporcionó material para uso experimental y acceso a la creación de prototipos de forma gratuita y no participó en análisis o diseño experimental. Las opiniones presentadas son míos y no de Boston Children's Hospital y recibimos fondos generosos del Fondo de Innovación del presidente de Richard y Susan F. Smith, y eso es un fondo de Boston Children's Hospital. Una divulgación más. Español fue mi peor asignatura en toda la escuela secundaria y señora Muñoz y señora España, a quien pasaría 2 años tratando de arreglarme. Y esta es mi primera presentación en español desde 1998, cuando tomé mi último examen en español. Ok, prometo que dar lo mejor de mí. Me tomaré un breve descanso en unos minutos. Si prefieres que continúe en inglés, no me ofenderé. Ok.
Puedes hacer de la forma que te sientas más cómodo, por favor, Michael.
Ok. ¿Mejor en inglés, crees, o en español?
Anyone you can. Anyone your choice is good for us. No problem. That better if you do in little Spanish, because there are a lot of people that don't speak English.
Okay, entonces voy a tratar de hacerlo en español.
Okay, thank you very much.
Tengo muchas personas de agradecer. Ok, aquí son los objetivos de la conferencia. Ok, vamos vamos a revisar las indicaciones de intervención, revise los tipos de intervención disponibles para el LUTO, los stents plásticos de WJ, cystoscopía fetal y amnio-infusion en serie y nuevos tipos de derivaciones. Primero, ¿por qué usa ese término LUTO para obstrucción del tracto urinario fetal? Y yo lo prefiero porque refleja la incertidumbre que tenemos en la hora de asesorar a una familia cuando reciben ese diagnóstico. Por lo general, la madre tiene entre 18 y 20 semanas de gestación se detectó la anatomía y hay niveles altos de estrés y incertidumbre. Deseo enfatizar que realmente no sabemos en ese momento cuál es el diagnóstico y los resultados son muy variables. Las etiologías, válvulas uretras posteriores, atresia uretral, síndrome de Eagle-Barrett, válvulas uretrales anteriores o divertículos, megalouretra o urethral. Ok. Eso es una prueba rápida por su cuenta privada sobre el Pluto. Entonces, ¿qué piensan? Que es probablemente es una prueba positiva, es decir, a poner un VAS probablemente sea útil para el LUTO, pero se ve obstaculizado por problemas estudio estructural, que probablemente es una prueba negativa. No días una respuesta definitiva o era un planeta. Ok, entonces es lo primero, probablemente es una prueba positiva. Y eso es lo que piensan los authors del estudio también. Entonces, fue un ensayo aleatorio de fetos masculinos con luto, sin selección. ¿Okay? Eso es VAS y observación. Y lo hacen en Reino Unido, Irlanda, Países Bajos. Necesario más de 150 pacientes por un beta de 0.2. Eso es lo mismo de decir poder de 80, eso es normal en ese tipo de prueba, pero solamente tenía 31 embarazadas que había aleatorizadas. Ok, 8 en 16 asignado a la VAS sobrevivió, pero solamente 4 en 15 asignado a observación sobrevivió. Hay diferentes tipos de análisis. La intención de tratar es ideal. El análisis tratado puede ser apropiado dada la contaminación sustantiva. Mucha gente en esa prueba ha cruzado. Se trataron 2 embarazadas asignadas al manejo de observación y se observaron 3 embarazados asignados a tratamiento. Entonces hay casi 5 en 32, 15% de las pacientes en esa prueba cruzados. Eso significa que ese es un estudio con una cantidad relativamente alta de contaminación. Ok, sinceramente, ¿es mejor seguir en español o en inglés?
Okay, Michael, anything you want. If you want to follow in English, it's okay for us, of course, no problem.
Okay,
Everybody's
German, is it making sense or no?
No,
Not
no,
really.
it's okay. But if you feel better to speak in English and you feel comfortable, it's good for us also. No problem.
Okay, I think I'll take the hint and proceed then in English.
Okay. Okay.
So there are 2 different types of analysis. So intention to treat is ideal, as I was saying. But if there are many people that cross over one arm to another, then it's better to use the actually as treated arm. And here's the data I was showing here. So what they show here in the in the as treated analysis is that the odds of the survival here are approximately 3-fold higher in those who had the shunt placed. This is a very powerful effect. And if this seems implausible, those trials before this and the meta-analysis support exactly the same thing, that perinatal survival is improved with a vesicoamniotic shunt. It's approximately 3-fold higher. Most importantly, candidate selection should be considered. So it has to be a singleton male fetus. So with the exception of probably the best result in all of LUTO, which is a prolapsed urethral in a girl, because this can be punctured with a needle, and this works very well. They should have a normal karyotype. And this is only done in the case of severe oligohydramnios or anhydramnios. with imaging showing suspicion for early obstruction. Favorable urinary electrolytes, we'll get into that in just a moment, as I recommended. So for the boards, studies that predict end-stage renal disease, it's having a sodium less than 100. Excuse me, these are favorable urinary indices. So these parameters, as shown here, are those that indicate likely better renal function, specifically better fetal renal function. So sodium solio less than 100, chloride less than 90, osmolarity less than 200, beta-2 microglobulin is low. Now, what low means varies by center. So it could be less than 2 milligrams. That would be wonderful. But some centers will select as high as 4 or 5.6 or even 6. It's easier just to think that lower is better. The way I remember all of this is that a functional kidney creates a plasma barrier. It does not spill protein from the blood into the plasma. So if the plasma resembles if the urine resembles plasma, high levels of sodium, high levels of protein, you've shown that the kidney is just has holes in the filter, so to speak. So this is, I think, the best staging system at present. This is Rodrigo Orano came up with this. It's currently in Mayo, and there are 3 stages of LUTO. Now, exactly how you are in each stage isn't quite clear. Like if you have 1 parameter of stage 2 and most of stage 1, are you a 2 or a 1? This is not clear. But overall, I think it gives a fair picture of what LUTO staging looks like. So if you have mild LUTO, normal amniotic fluid, normal appearance of the kidneys, you should not shunt. There's no role for intervention, unambiguous. Stage 2 LUTO, this is the classic time to intervene with a vesicoamniotic shunt. Allohydramnios or anhydramnios, especially if it's happening early, suddenly. Echogenic kidneys, but favorable urinary electrolytes. Stage 3 LUTO, these are the babies most affected. Severe CKD, allohydramnios, almost always anhydramnios, cystic development in the kidneys, severe dysplasia. Fetal intervention is tricky here because traditionally we haven't done it. The studies in which there is very little selection of patients actually show that these babies may be aided more by a shunt, but they would be expected to progress to the need to transplant, potentially have other complications in the perinatal period from surviving with severe CKD. So shunting. Folks okay so far? Okay. So shunt, it's relatively straightforward. So this is a little cartoon here. Bladder outlet obstruction, urine not contributing to amniotic fluid, hydronephrosis, renal dysplasia, and it's causing Potter sequence A. And this is the classic, what we see classically with LUTO. So a shunt is relatively simple. There's a tube. You introduce this tube through the fetal abdomen into the bladder. A plastic tube goes into this, and when you retract it, it forms the double J. This is the same shunt that's been available since the early 1980s. There are 2 that are on the market now. Harrison shunt, which is by Cook Medical. It's delivered through a 13-gauge needle. So it's a thick needle, but still thinner than all the other devices. And it's a 5 French catheter. Little side holes, very thin. The Rocket shunt from England. This is a much, much larger introducer, over about twice the diameter. I'll show you in a moment. And the shunt is much more rigid and has coils on each side. These are reinforced with metal, but it's still potentially possible to do an MRI. So the problem is that these shunts, they fall out. They fall out for a variety of reasons. It's not clear whether they're clogging or whether the babies are grasping these shunts and then forcibly dislodging them. But in any event, it's quite clear that if a patient has a shunt, it's possible that they will need more than 1 shunt in the pregnancy. This is a serious problem for women. So when we look at displacements of shunts, this is just a single center series. It shows that the shunts here, this is the Rocket shunt, I should say, and it's more resistant to dislodgement, but still, maybe 30% of the cases, it needs to be replaced. And the Harrison stent here falls out an awful lot in this series. So about 70% of the time, you would need to place another one, maybe even another one after that. And this is our experience in referrals or patients that we've managed. These Harrison shunts tend to dislodge. Ruben Quintero modified the shunt around 2010. It's clever. So he used this device here, which is made of wire, which is an atrial septal closure device. and it's around the Harrison stent. And so the idea is that the mesh is entangled around the catheter, so both become embedded in the fetal abdominal wall. And to the extent that it's designed to resist dislodgement, it works. The problem is that it's you then have to surgically cut it out from the abdominal wall as the tissue grows into it. Best has been reported. So there's definitely some opportunity for development for a shunt that perhaps doesn't have those properties. Serial amnio-infusion. So there are two important ways that this can be approached. One is called an amnioport. This is the way it's been done for a little while in Cincinnati. So what they do is you take a port just like you would for, say, for chemotherapy, and you place it in a pocket beneath the maternal skin here, and then a small laparotomy is required because this cannot be placed directly into the womb. It has to be placed on a long angle, so a tunnel is created to resist leakage of amniotic fluid. The coil is then placed in the womb, and what's important here is that this then can be accessed and given fluid. Now, when this is done, this is often done many times during pregnancy. And the series they reported here is between 2 and 21 times. Median is around a dozen times. So you're thinking you really are restoring the amniotic fluid serially. It's not just a one-time thing. And similarly, it's you're avoiding accessing the womb with a needle over and over during the study. But there are some problems. Sometimes they dislodge. This can pass through the vagina, or it can slide out from the uterus. There was one case of preterm premature rupture of membranes. That's what's most severe. When they infuse, they give about 400 cc's at a time, so they restore a normal physiologic volume. And there were 4 of 8 long-term survivors, one case of lethal pulmonary hypoplasia. So that's reassuring. So the RAFT trial is very exciting. This is a different approach to the same disease process. So this is a multi-center trial. It's based at Hopkins, purely percutaneous, which means that the needle will be placed into the womb and amniotic fluid restored this way, the traditional way, without the use of the port. It's inspired by some encouraging results that hit the news about 10 years ago now in bilateral renal agenesis. And inclusion criteria for this are very broad. Could be LUTO, could be bilateral renal agenesis, any form of fetal generated anhydramnios. There's some wise words of caution from Dr. Caldemon's colleague, Dr. Francois Laux, is one of my favorite fetal surgeons. And what he warns against is that these rapid, when amnio-infusion was presented to the public, it was presented probably in a way that was a little too positive based on the scientific results at the time. And it's good to be cautious always in these contexts. One issue is that saline and ringers are simple fluids, and they're very different from amniotic fluid. So expired fluid from the lungs, passage of fluid through the fetal skin. That's one of my favorite facts, is that early in gestation, a large volume of fluid passes directly from the amniotic space directly through the fetal skin. And again, this fluid is the constituency of very different than, say, something just like 2 ions in water. So this is a very exciting trial. It's important to have these large, randomized, publicly viewed trials in fetal literature, which often is troubled by having very small centers. Results reported retrospectively, all kinds of risk of bias with those. And amnio-infusion deserves a large trial. I think eyes will be watching for chorioamnionitis. That's the main thing that the obstetricians tell me they're concerned about with accessing the wound over and over, similar to having, say, a amniocentesis serially. We know there's risk with just one, and there's a risk of preterm labor with the amnio-infusion. So the outcomes from pulmonary hypoplasia, I suspect, will be favorable, but the other two, I certainly hope they'll be positive. So fetal cystoscopy, this kind of makes the most sense for us as urologists. Like, there's a problem, we can fix it through the endoscope. Why not address it directly in utero? This avoids any problem with accessing the wound multiple times because you've cured the problem straight away. Similarly, it avoids any problem with the shunt. If you go straight ahead and fix the problem in the urethra, then the urine will pass through the urethra and you don't need any plastic devices. So this was reported in The Lancet around 2000. And this, of course, is access from above. There's no attempt at retrograde urethral access in the fetus. Here's some views. This happens to be with a larger scope, really nice view here. But when you're intervening, it's with a relatively small scope. It's about just a few millimeters wide. And you can see the laser fiber here. The problem is that it's hard. And even when the scope is curved, the angle to get down the urethra is very tricky, especially if, say, there's an elevated bladder neck. And so some of the laser energy can be directed posteriorly. So I commend these authors for publishing the complications here. And you can see that in some cases there's spinal complications or posterior fistulas to the rectum. In short, it's just very, it's very hard with semi-rigid equipment to make this turn in a fetus that you don't fully have control over their position in order to get down the urethra reliably. Also, if you remember what I was saying at the very beginning, or which I'm tempted to say, because at that point I was speaking in Spanish, there's trouble with diagnosis, right? You don't know whether it's LUTO, whether it's a valve. It could be urethral atresia. And if you're just going from above with an endoscope, you don't know that in the moment that you're treating. And you might be attempting to use laser energy to travel in a direction that, that you really shouldn't. So for this reason, my lab is working on a new type of shunt. This is derived from biliary stents. They're called lumen opposing stents. And some very clever gastroenterologists developed them for pancreatic pseudocysts. So the idea here that you would take a device through an EGD and using ultrasound, go through the wall of the stomach, drain it to a pancreatic pseudocyst, and then you need some form of stent to make sure that the lumen of the pseudocyst and the lumen of the stomach then become opposed. And this is what the stent looks like. So this is just a video of just me holding it. They call this middle part the saddle, and these are flared ends. You can see it's nitinol and a silicone web. It's really soft. The silicone coats just the outside here. Silicone actually is what gives it most of its strength. It's very surprising to me. That's what the engineers tell me. And you can see that when you stretch it, it sort of stretches and becomes thinner. And when you relax it, the saddle in the middle becomes much wider. And we had to develop completely de novo. This is just actually this is one of the earlier prototypes. This shunt is very old. You'll see it has some fraying on the ends, but this is the concept here. So it's delivered in this tube here. You protrude the trocar from the end, and in the shunt it just self-expands because that's what it wants to do. It has nitinol, so it has memory. So the shunt itself expands on all sides, and then it allows itself to sit secured within the fetal abdominal wall. And just showing you here again, it expands to a lumen larger than the device here. So you can just withdraw the trocar through the middle. You can see the hole is just much bigger than the diameter of the device that was used to deliver it. So one thing we were concerned about is, well, how easy is this to dislodge? And we're pleased to see that our shunt here is way more resistant to dislodgement. If you just measure the force that it takes to pull it out through a simulated fetal abdomen, you can see it requires a very short, strong pull in order to dislodge it, and then the device will fail, meaning you can dislodge it. Whereas a Harrison shunt slides right out, and a rocket shunt's kind of in between. It's kind of what you would predict. This is in the fetal lamb. You can see how we're measuring the force here. Very simple, just a spring scale here. And you can see you're pulling awfully hard to try to dislodge this. And you can see that the flared end of the shunt, I'm sorry, it's just at the bottom of the screen there, is still holding on, but it takes a lot of force to attempt to dislodge it. And here's a still picture over on this side of the screen showing that it really does take quite a bit of force to dislodge it. This is just a schematic of how it's delivered. So you can see that there's a pusher that's behind it that's integrated, and then this the end needs to protrude just slightly, and the stent comes around it, just like I was showing you in the video earlier. So, well, what size delivery device? And I'm going to emphasize this quite a bit because this is what the obstetricians are concerned about. When nobody truly knows what causes preterm rupture of membranes, or worse, membrane separation. So as the device is passed through the uterine wall, whether the membranes will peel away from the inside of the myometrium. And clearly a smaller hole is a better thing. So a Harrison device, it's hard to beat this because it's so small and the shunt is small. I don't think there's going to be any type of this device that will be able to be delivered through a device this small, simply because the wall, the silicone, can only be compressed so thin. So our device is in between. It's still way smaller than the rocket delivery system, which is neat because the lumen, of course, is much larger. I would say it's like a ship in the bottle. You want to develop something larger through a very small opening. So it has a very large internal diameter. There's a micrometer here. It's about 4.8 millimeters, which is way bigger than the 1 millimeter plastic shunts. Another way to think of this is like when you think of your patients, like who are, say, on the floor after surgery, we as urologists, you'd never drain somebody with a 1 millimeter wide tube and expect that to remain patent without any flushing, without any intervention. But of course, this is exactly what we're proposing with these fetal stents, that somehow this tiny little lumen, and we know that there's bladder debris, and even every once in a while the amniotic fluid has some, you can just see there's some cellular debris in it, would remain patent. So I think a larger lumen certainly will resist dislodgement. What this appears to leave is, oh, sorry, I'll just show you a video here placement. So this is what it looks like on ultrasound here, this big fetal bladder. You can see it dilate posterior there. So this is an open placement here. It's one of our earlier tests. This happens to be a female lamb, you can see. But when we place it into the bladder here, then just pull it out, you can see that it sort of sits within the fetal abdominal wall. This is the obstructed bladder, which then drains freely. So that's the relief of the obstruction. Oh, of course, it's extremely easy to see on ultrasound because it's made out of a nitinol. It's a metal weave. So there are tons of internal echo. You can see the barbell here, just like this. That makes it much easier for us. Placing a shunt, I'm not sure how many of you have actually seen or placed yourselves the vesicoamniotic shunt, the classic double J plastic one, but it's hard. Accessing the bladder is quite tricky. You don't have very much time between putting the needle in the bladder, having to load the stent before the bladder starts to drain. And then one of the trickiest parts is making sure that the coil is delivered into the amniotic space. There's almost no fluid. You'd typically have to amnio-infuse beforehand to restore a little bit of amniotic fluid volume to place the coil on the, to place it in the amniotic space. This one, it's the stent sort of shrinks down to its position, hugging the abdominal wall, which makes it a lot easier technically. On histology, this is a non-shunted control. This is our shunted lamb. We didn't see fibrosis. This is the area where the shunt itself. You can see there is some thickening in the urothelium here, I think it's fair to say. But what it does is it leaves a fully epithelialized tract. And that's what we were worried about the most is, gosh, we know that this works in the context of, say, a pancreatic pseudocyst, where you can oppose the two lumens and there doesn't appear to be leakage, but nobody knows about fetal healing. Is there, in this context, are we going to be in a situation where there's tissue ingrowth, where the fetus heals into the shunt, and just like the Dr. Quintero shunt, are we going to have to surgically excise this? That would be less than ideal. In all the shunts we've placed, that has not been the case. So I think we're in exciting times for LUTO. There are more precise grading systems for diagnosis classification. There are more rigorous trials with more rigorous follow-up, the RAF trial for sure, and potentially some new techniques for intervention. I'll move on to diagnosis, if that's okay, German?
Yeah, it's okay. It's okay.
Okay. So this is a different effort at our lab, different approach to the same disease. So traditional measurement of renal function requires a bladder aspiration, means placing a needle into the fetal bladder. This is the standard care prior shunt placement. I mentioned this a couple times earlier. You measure sodium chloride, osmolality, the proteins. This has also been unchanged since the 80s. The problem is it's not always benign. Placing a needle into the bladder can result in urinary ascites, even potentially a fetal bladder rupture. So the question is, can you do something more sophisticated? Can we use an MRI? If you place the mom and the baby in the MRI, localize the bladder in space, and take a voxel of this urine, a virtual cube of this urine, can you then analyze this voxel and see what the chemical components are? So it seems like magical, and you can't measure everything. So simple hydrocarbons, ideal. Amino acids, creatinine and the creatines, lactate, glucose, those are perfect because they have distinct signals. They can't be too small. Ions, of course, would have no signal at all. This is an NMR, similar to ones you may have used in organic chemistry lab. It can't be too large because, again, the signal is too complex, it's too muddy. So fortunately, some elegant work was done in France in the 1990s, where they aspirated many fetal bladders with this condition, with LUTO, divided them into 3 groups: good group, poor group, and a group that died due to renal dysplasia. And you can see here that the levels of threonine and lactate, I'm using threonine here because its NMR signal is almost identical to lactate. You have almost none in the good group. You start to spill more in the poor group, and there's a ton of it. Really, it's a very high volume of lactate. in the fatal renal dysplasia group. So we did some phantom experiments first. We took some human urine, we added lactate, and sure enough, at this chemical shift, you can see urinary lactate. The reason this is special is that if you run the sequences at just the right relaxation time, just the right sequence on the MRI, you can see that the lactate flips. Can you? It's kind of fine on the screen here, but this little white line, there's this upside down doublet. So around 1.4, 1.3, 1.4 parts per million. That's the chemical shift. So we wanted to study this because it's no risk, right? It's just an MRI, no IV is placed, no sedation is needed. For mothers who are likely undergoing MRI anyway, to see if we can chemically assess the fetal urine. And so we recruited pregnant women with LUTO, severe hydronephrosis, because you could put that voxel in the kidney, or a urinoma. And we happen to use a 3T MRI. We did most of our experiments on the 1.5T MRI, which is what most folks would have in their hospital, just a standard one. And it works there too. But this just happens to be our fetal scanner. So this is a patient with stage 3 LUTO. And you can see that there's this doublet right around the same chemical shift. We had a whole bunch of patients recruited. Actually, this is older data. We have more than 10 now who underwent this study, and sometimes it seems to work. So in the case of anhydramnios, we detected a case of lactate. Perinephric urinoma, we did not detect lactate. It's tough to say what's actually going on chemically in a urinoma. Oh, this is a neat one. So this is the 2%. We had a baby who, after birth, we ended up having a DMSA, and sure enough, there's 2% function in this very dysplastic upper pole, and there's lactate detected in that dysplastic upper pole's urine. Now, I should say it up front, there's limitations, right? You need to be able to localize this on the MRI and select a large volume of space. And so it needs to be at least a centimeter, ideally closer to 3 centimeters, because you want to be able to put a 1.5 centimeter edged cube in that space without getting outside the bladder. We had a case in megacystis megaurine. There's a lot of fluid, so the baby's moving around a lot. So this was like a technical failure. We had a case of anhydramnios with a fetal shunt, but we were measuring the fetal urinary ascites in which the lactate is likely already absorbed. This is another case of PUV. This is a case, a recent one. So this, I think, is really illustrative. So this is the MRI here with all the spatial resolution. Okay, so this is the fetal bladder you can see here. You can imagine that this is where the valves are. I can't tell if this is the urethra coming around here, but clearly it's a case of severe obstruction. You can see that there's not this little line here is the amniotic fluid, and this is at 20 weeks. So of course there should be far more fluid. Anhydramnios, it's severe. The placenta is edematous in this case. So this is a case of severe distress. And if you look very closely, this is one of the kidneys. Here's the other kidney here, and it's extremely dysplastic. This is a cyst here. These are actually also just elements of cystic renal dysplasia. This is not corticomedullary differentiation. So this is what in the Ruano stage would be another stage 3 LUTO. And you can see here, remember the doublet I was looking at earlier? You can see at 1.4 parts per million, there's this very sharp and distinct doublet. This, I should explain on the left. You always get a huge water signal. That's the first thing that comes out of the NMR, but this is obvious, right? This just shows that you're looking at water. So we're zooming in on this area here. When I show you all this. So it is a noisy study. This is what NMRs look like, but I think if you're, at least if you're like me, you can be convinced that at this area of chemical shift, you can detect a urinary lactate. And what's, I think, great about this is that this is a true biochemical assessment of what's going on inside the fetal bladder. So we have to make a serious decision for these expectant mothers, which is that are you going to place a shunt, which may have all these complications associated with it? So basing it on imaging alone, saying they're renal cysts, or perhaps just the structure of the fetal bladder, that's probably not sufficient. So in a way to avoid a biopsy, if you can get actual chemical data which reflects the structure of the kidney, then that would be, I think, important. So there are problems, correct? It's a rare disease. So we have a very small sample size. Only dilated structures. Remember I was saying earlier, it has to be a large target to use the MRI. And some scans are simply not feasible. If the baby is moving too much, you can't acquire this. It takes about 90 seconds, ideally 3 minutes to acquire the scan. And in the most affected babies, those with anhydramnios, in this case, you can expect the bladder to remain largely in the same position. But in case of megacystis megaurine, where there's copious amniotic fluid and the baby's floating around, when you scan beforehand, run your 90-second sequence and scan again, the baby may have moved, in which case the data is questionable. So in our preliminary data, this spectroscopy, we obtained usable spectra. In cases of severe renal dysplasia, in those two cases I showed you most specifically, a lactate peak is detectable. So I think it has a potential to serve as a functional test of renal dysplasia. I mean, with many caveats, it's so early, but I think it has this potential to avoid the need for vesicocentesis. I have lots of collaborators for this portion of the study, for whom I'm very grateful. Anyway, that's what I'd prepared for you folks this morning. This is my impression of what's going on in the world of fetal lower urinary tract obstruction, the role for intervention, and the diagnostic studies that might lead up to it. So again, thank you so much for your patience, especially for my bumbling Spanish at the beginning, and for inviting me to speak today. Again, on one of my favorite topics. I'd be happy to answer any questions you all might have.
Thank you very much. Muchas gracias, Michael. Muchas gracias. ¿Me puedes devolver el comando para que pueda?
Oh, yeah, por supuesto. Pero espera un minuto. Tiene que mover eso.
Okay,
And
perfecto.
then...
Estamos muy bien. Perfecto. Gracias. Ok. ¿Algún comentario? Anthony, do you want to comment something? Anthony, please.
Sure. Michael, that was a brilliant presentation. I'm so impressed that you're really on the forefront of what's going on in fetal intervention and diagnosis as well. I was aware of your shunt work, of course, because I think I had heard you present it not that long ago, but I did not know anything about the diagnosis phase of it, and that's very, very exciting. Just a couple of practical questions for you, things that I've struggled with over the course of my career that I wonder if you could shed some light on. Have you had to deal with any cases of obvious lower urinary tract obstruction involving a twin pregnancy? And I wonder if you could speak to not only the technical issues associated with it, but maybe the ethical issues associated with intervention as well. I know it's a very complex and maybe an hour discussion, I don't know, but would appreciate your thoughts on it, Michael.
Yeah, thanks, Dr. Calderon. That particular circumstance hasn't presented itself to me yet, but it has to our hospital. I think there was a recent presentation from Mayo on exactly this type of case, where when you have one affected fetus. Oh, I take it back. We did have a case, but it was potentially like a UG sinus ARM. It wasn't exactly clear whether it was LUTO or not. In our center, we have not been intervening for those. And it's so tricky, right? Because I think if you're going to consent a family honestly, fairly, for a shunt intervention now, you're consenting them for a median of 2 shunts. So whatever risk there is, you're accumulating twice, and then for both fetuses. So I think it's I think at present it's a hard choice, but given the lack of safety you're talking for like a MODI,
right,
or excuse me, a di-di twin situation, most likely, where you have this situation. Yeah, most likely we'd encourage more of an observational approach. A really tough question, Dr. Calderon. Yeah, nobody's got the good answer there.
Well, I don't think there is an answer for that. You're absolutely right. And as I said, the ethics that brings up is just very, very difficult to deal with.
For sure.
Nuncio, ¿algún comentario? Any comment, Nuncio?
Yo gostaria de complementar Michael Kurtz por la excelente charla. Y ahora las medidas de los índices urinarios, yo creo que es un camino, un nuevo camino para se poder monitorar esses fetos antes de uma intervenção que muitas vezes é lesiva ao feto e à la madre. Eu creio que esse caminho é um caminho muito bueno que nós temos que trilhar agora.
Yeah, well, thank you. I mean, muchas gracias. I think it's finding another way to measure these urinary indices, I think would be important. They will be different. So lactate, it's different than measuring, say, the standard protein or sodium, but that's what's available to us on the MRI. And I think it's a good way to proceed.
Una pregunta, Michael. ¿Han hecho una correlación clínica entre los resultados químicos de la amniocentesis y los resultados del MRI?
No. So eso es una limitación grande. So en estudio ideal había hacer un MRI y inmediatamente después sacarle el líquido de la vejiga y medir si es lo mismo o no. Pero la mayoría del tiempo no es posible. So, en algunos casos, si solamente es una parte de la riñón que es displástico, no se puede aspirar ese orina. That's like unethical. And in other cases, los madres no se quisieran porque es un luto it's like a stage 1 luto, or no quisieran un shunt. So, entonces no tenemos esa correlación. No sé cómo se dice.
Correlación, perfecto.
Okay. So ese sería mejor, pero no lo tenemos esa data.
Perfecto. There are people that saying that you replenishes so well.
Oh, that's very nice. Okay, I try my best.
Hay una pregunta. ¿Es necesario anestesia a la madre y al bebé para disminuir el movimiento durante la resonancia?
No, porque es tan rápido. Entonces no ponemos ningún suero, ninguna anestesia. Cada vez que hace anestesia a la madre, hay mucho riesgo con eso. Y en realidad, cuando se pone ese shunt, ese VAS, esa diversación, la mayoría del tiempo cuando lo pone, no necesita anestesia general. Usan epidural y algunas veces un poco sedation. Pero la mayoría del tiempo no, porque hay gran riesgo con eso. No hay ninguna anestesia con eso, no hay ningún medicamento, solamente hacer un MRI normal. Y de 1.5 Tesla está suficiente, no necesita fancy MRI de 3 Tesla.
Any comment, Tony? No?
I didn't understand the question.
Sorry. Do you need to anesthetize the mom for the MRI?
Oh, yeah, that's right.
Yeah, that would be a big deal if you did. Plus, fetal motion is tricky. So, like, even when you place a shunt, even with the epidural, or even the rare cases where the mom is under GA, the anesthesiologist, fetal anesthesiologist, still deliver a paralytic to the fetus. I should say also another limitation is that fetal lambs, like when I showed my data on the sheep, they don't seem to move as much in utero. I don't know why, but it's easier for us to place a shunt in some ways. It's much harder in others because the uterus in a lamb is a nightmare. It has, instead of having a single placenta, you have like 12 tiny placentas. So it makes it very hard to, it's just how they're built. But yeah, fetal motion is an important consideration in many regards here.
Another question we have here, if polyhydramnios is the main indication for LUTO intervention, why you don't do this before to prevent the kidney damage? And maybe the question is, when is the lowest age you can do the intervention?
Yeah, so traditionally for shunting, the earliest I've seen it is about 16 weeks. And at that point, you almost certainly have to use the Harrison, because 16, 17 semanas. So yeah, hay casos, there are very rare cases in which the LUTO is detected extremely early. So in the United States, typically a mom will get a scan 18 to 20 weeks. We call this the anatomy scan. That's when most LUTO is detected. And that's when we are in this rush to determine, do you need to treat, or are you going to observe? There is a scan also at 8 weeks, 8 to 10 weeks. Every once in a while, it's very rare. I've only seen one case where they've detected LUTO at that stage. And then it's very difficult. I have not seen that a fetus with that condition make it to term. So that's very hard for the family. But yeah, the trouble is, I read Dr. Calderon's work in Campbell's. Fetal renal development starts at the 4th week gestation. If you have dysplasia, I don't know if we're ever going to be able to reliably stop the development of renal dysplasia with a shunt. The primary goal there are three goals of shunting. The first is to restore amniotic fluid volume for survival, both in the womb to avoid compression of the umbilical cord, and secondly for the perinatal survival for pulmonary hypoplasia. The second goal below that is renal function. Nobody knows if that will improve. And then the third is to see if bladder dynamics are perhaps improved. But that is a tertiary goal. The primary goal is just to make it beyond a month to live outside the NICU.
We have another question here.
Yeah.
Do we need always the electrolyte urine to do the amnio-shunting?
Right. Yeah, currently that's the standard of care. There is that really intriguing data. Dr. Morris from the UK, Morris, if you're curious, her work is the best in this. What's curious is that in one of these studies, the odds of survival were dramatically improved for shunting with babies with poor urinary indices. So that goes against much of what we're thinking. The reason I think it's smart is this. I only showed you 3 stages of the Ruano classification. He published another paper, and I think he's a good, he's a very reliable author in this because he has so much experience. You can imagine a 4th stage called in utero renal failure. And I've seen cases of this where the renal dysplasia is so poor. In other words, your urinary electrolytes are going to be so terrible that even if you place the shunt, the kidneys aren't going to even produce liquid. In other words, they're not like remember how I said like a poor function kidney is like a filter with a lot of holes in it? If you're not even producing fluid, if you place a shunt, you won't restore the volume. In that case, your only option is some sort of external replacement of fluid, a amnioport, serial amniocentesis like the RAF study. You would abandon the fetal kidney. So I think given the current risks of chorioamnionitis, shunt dislodgement, shunt-related complications, abdominal wall hernia, all the things that potentially go along with a shunt placement, I think it is worth knowing to make sure you don't have the worst case scenario, a potential progression to in utero renal failure before shunt placement. Long answer, sorry.
Okay. ¿Cuál es la mejor edad para hacer la resonancia?
Puede ser cualquier edad. Lo más importante es que tiene más espacio para poner ese voxel de MRI. Entonces, la mayoría del tiempo simplemente es casi 20, 21, 22. Eso es edad de gestación cuando vemos los infantes, porque tiene esa prueba diagnóstico casi una semana antes. Y llega a Boston Children's Hospital y lo hacemos.
One question I have, how you deal with legal problems to do this intervention? How do you manage it?
Can you clarify?
Yeah, maybe you can have legal problems making these interventions because maybe you can bad results.
Oh,
how do you do that?
Yeah, well, I have not run into this at present, but yes, I think any conversation regarding shunting involves what I showed you today, which I think is an honest appraisal of what the data is like today. I think if you promise expecting mother, a family, that your shunt is going to work, going to cure their lung problems and potentially their kidney problems, I think that's a setup for failure because the expectations and reality will not match. I think if you're honest and say, we will do our best, and shunts often fail, they often dislodge, but the largest randomized controlled trial in the best way that we can interpret the data suggests that it improves survival. I think if you enter into that relationship together, I would hope that everybody would have reasonable expectations about the resulting course. But yeah, being overly optimistic in this field, I think is really dangerous, potentially with that type of manifestation. That's a really good point, German.
Okay.
I think if I could just make a comment on that, it's not that dissimilar from intervention for meningomyelocele, where you have to manage expectations, don't you? The potential positive outcome is pretty significant, as the mom's trial have shown, but we still have a group that won't benefit from it, and we still have a group where we certainly don't know what the long-term benefits are regarding urinary tract function is concerned. So I think Michael's point in any of these on-the-edge experimental types of works that we do, that managing expectations is probably the most important thing that we can do.
¿Alguna pregunta?
Mm.
Any question for him? Okay, we have another one here. Please. Is Ruanus the only protocol for fetal intervention?
No, hay muchísimos. Many hospitals will have them, and some publish them. Texas used to have an algorithm when Rodrigo was there. Yeah, every hospital has their own consideration. As far as the staging system, I think Ruano's is the most comprehensive. Prior systems used to be more binary, good, bad. But I think Ruano's, which is more nuanced, I think is superior, and based on his tremendous experience. So I support that. But every hospital has their own sort of algorithm. I should note that the talk of serial fetal interventions. So I mentioned only one set of electrolytes, but classically they're measured several times. There's a whole other talk I could give on why that may or may not be necessary. I do not think it's necessary. I think you can get a lot of information from the first aspirate, but every hospital is different.
Okay. Are there new ways to differentiate PUV from prune belly or urethral atresia prenatally?
Every time I talk to the obstetricians, that's what they ask me, because
This is Yanker question.
Oh, good. Yeah, you'd really want to know, right? So, I mean, their clues. Are the testes descended? What is the pattern of the ureteral dilation? An MRI may be able to help you with that, but no, you cannot know for sure. In fact, the real question I'd want to know is how do you know it's an atresia versus not? Because that affects things quite differently after birth, urethral atresia versus posterior urethral valves. But right now you can't tell. We just go off the classical signs for the triad syndrome. If you have undescended testis, lax appearing abdominal wall, dilated distal ureters, that would make you very suspicious for Eagle Barrett, prune belly. But you don't know until you get that cystogram, and there is no fetal cystogram yet, so you can't really tell.
This is one question that I have.
Yeah.
Which is the better choice? One vesicle punction, or maybe 2-3 vesicle punction to study the biochemistry of urine? What is the better recommendation?
Right. So my hope for the future is 0, because we'd be using the MRI.
MRI, yeah.
But if you had to do it, I think you can get a lot of information from one. The serial results do change if you measure it over time, but you're talking about relatively modest changes in sodium. I have another talk on this. I think in the data from Johnson, it was like maybe 7. The median change was like 7 milligrams per deciliter for the sodium change over time, which again, if you're talking about like whether it's 150 or 80, it doesn't really matter that much. So yes, urinary indices do change. The standard of care is still serial aspiration. And I don't mean to say anything I presented today changes the current standard of care, but yeah, I think you get an awful lot of information from that first aspirate. Because again, you're just trying to rule out that stage 4, the in utero renal failure, that's the worst, or really, really favorable urinary indices. Everything in between is a little less clear. So that's why I think a marker like lactate, where if you just have super high lactate, you'd say, I don't know, this is severe renal dysplasia, versus everything else, I think is useful. Okay.
There is a case here that somebody can to ask you. Yeah. We do have 14 weeks with megacystis now, and US evidence of LUTO. Is it appropriate to do a vesicosynthesis first to check the light, and then if the oligo appears and she qualifies, place the shunt at 16 and above?
That's the earliest I've seen a shunt placed. And this is a very delicate situation because in our experiences, in the pregnancies that are so severely affected do not always have a good outcome, no matter what you're doing. So I'd enter with extreme caution. Yeah, it's been done before. It's certainly been reported, done this way for a long time, for many decades. So there is precedent for aspiration and placing a shunt. 16 would be the extreme end of it. And if you're going to do it, the Harrison shunt probably is the right shunt to use. But yes, it's very risky. You'd want to have a serious conversation with the family about their expectations beforehand for exactly the question you had earlier, German. De los riesgos legales y de otras cosas. Yeah.
We have another one here.
Wow.
I will try to translate this. It's not easy. If the placent is anterior, dorsal of the fetus is a limitant for vesicle shunting?
Yeah, se puede usarlo. Hay algunos casos de poner ese nudo directamente por el placenta. Hay más riesgo de sangrar, pero it's been done. Typically at that point, again, a Harrison shunt, a smaller needle is possible. If there are circumstances in which you can attempt to shunt from a posterior approach. This requires a much greater degree of invasiveness. You would need to perform a C-section type incision, deliver the uterus outward, and puncture from before. I've seen Rodrigo do this, so it's possible, but obviously that's a much more morbid for the mom. But yeah, if you look closely at some of these series, maybe 30% of them are transplacental. Again, more risk, but it certainly is possible. I have not tested our shunt that way, again, because of the unusual womb arrangement for sheep.
I have my question is, which is the tendency actually in USA to do the valve ablation or to do the shunt, vesical amniotic shunt? What is the current tendency?
I think there was much enthusiasm earlier for fetal cystoscopy. It's only done in a few centers, and it has those risks. I really commend the authors from Texas for showing that data with the posterior location of energy. I'll just be honest, I've said this before in public, I think a valve ablation in a baby is hard. Like you have to be very careful. Even in a full-term neonate, when you have a resectoscope, surgical paralysis. So approaching it from above into an unknown urethra is a little risky. It's possible, I could imagine some modifications where it could become safer potentially in the future, probing the urethra. But yeah, a valve ablation is, I would consider that quite remaining. I would still consider that more on the frontier rather than like standard of care. So yes, far more shunts seem to be placed than fetal valve ablations fetoscopically.
Thank you. We have a few minutes more, and the percentage of renal insufficiency between shunt and no shunt, which is the difference, the percentage of difference?
We can't tell because there's such profound selection bias. So you're only shunting solamente lo pone por los bebés más afectivos, right? So like the babies that already have the worst function, those get the shunt. And then the babies that are better off, they don't. So I think it's too early to say if a shunt improves renal dysplasia. It can improve hydronephrosis, for sure. But whether that affects actual renal development, which again happens starting, there's significant development around the 5th week. And if this blockage happens around the 8th week, this dysplasia could be too early. So I think the most promising results are restoring amniotic fluid volume and examining the complications in the lung.
The last question. If you have a late diagnosis for LUTO, do you put the spontaneous, do you wait for spontaneous delivery, or you do in advance?
Lo más que puede, espera, porque si necesita diálisis, es mejor tener un bebé más grande. Okay. Lo peor situación es un bebé demasiado pequeño por diálisis y no se puede ayudar con la quimiometría de la sangre, que es demasiado afectivo. So the nephrologists, the kidney doctors, they want us to wait as long as possible. Now, the maternal fetal medicine specialists are concerned about cord compression, which could be fatal, right? So they are watched extremely closely with ultrasounds. But yeah, the bigger the baby, the better, for sure, for many reasons, but especially the potential need for peritoneal dialysis. If you can't do it if they're too small.
Okay. Tony, Nuncio, any question for him? Any comment?
Oh, just Michael, just an excellent job. I can't comment on your Spanish, but you seem to be able to deliver it quite easily. So I don't think you struggled at all. And I suspected it was very, very good. But more importantly, I think the content and where you're going with your work is just outstanding. I enjoyed the presentation very much.
Well, thank you, Master. Yes, very nice of you.
Nuncio, ¿algún comentario?
No questions. Congratulations to Mike.
Okay, muchas gracias, Lucio.
Muy bien.
Okay.
Con esto damos por finalizado la presentación del doctor Michael Kurtz. Michael, thank you very much for your presence. As I told you, you have to come to Bolivia and to make a workshop with Tony. First, I have to tell to Tony to make a mission to Bolivia. To go again, another mission. He knows how we work here.
Very well. I know very well. That's right.
Adjourn, yes, it'd be a huge honor. I hope to someday. Yes. Okay. Thank you so much for the wonderful questions and comments. I really appreciate it.
Gracias, muy amable. Muchas gracias a todos. Okay. Gracias por su presencia. Tony, Nuncio,
take care. Good to see everyone.
Michael.
Bye, Nuncio. Michael, great job.
Muchas gracias.
Bye, German.
Bye, Tony.